Hello, and thanks for taking the time to watch this video. The purpose for it is to make sure that everybody in the emergency department is kind of documenting sepsis the same way. There are many requirements we have to go through for each sepsis chart, and each chart is looked at. And because of that, it's important that we all know at least the basics of what's required on every sepsis chart, and how to do it the easiest so that it interferes with our workflow the least. It is a CMS requirement that all septic patients have certain elements done. And as I said, there's a sepsis committee and a sepsis coordinator, and all these charts are reviewed. I want to go through some definitions just to make sure we're all defining things the same way. Sepsis is an infection plus either two SIRS criteria or a quick SOFA score of at least 2. Severe sepsis is sepsis plus organ dysfunction, and there's a variety of definitions or criteria that you can call organ dysfunction. Most of them are up here. Acute renal failure. I do want to point out encephalopathy. So, a septic older person with a UTI who's delirious is actually in severe sepsis, even if everything else doesn't look too bad. But also decreased perfusion, low platelets, high INR, respiratory distress, a GI ileus, all would get you into that severe sepsis category. And finally, septic shock is sepsis plus hypotension, which is either a MAP of less than 65 or a systolic of less than 90 or a 40-point drop from their baseline blood pressure that's unresponsive to a crystalloid bolus or a lactate greater than 4. Any one of those things gets you into the septic shock category. CMS requires certain elements be done, bundle elements, within the first hour of sepsis onset. And it's a lot of stuff to do in an hour. You got to measure a lactate, and if it's greater than 2 at 3 hours, it needs to be remeasured. Blood cultures need to be obtained. Broad spectrum IV antibiotics need to be started. You need to start a crystalloid bolus of 30 mils per kilo if fitting any of those criteria for shock. Again, systolic less than 90, MAP less than 65, or a lactate of greater than 4. And note, there is some evidence that a balanced crystalloid such as lactated ringers or plasmolite is a little better than saline. And if persistently hypotensive or hypoperfused, you should start vasopressors. Levophed is the preferred starting agent, and there's a lot of data behind that. And if you need a second agent, fixed dose vasopressin is probably the next thing you reach for, in addition to the norepinephrine. 6-hour requirements. You have to repeat a volume status and tissue perfusion check and document that, and I'll show you how to do that. This is for patients in septic shock. You can either do a focused physical exam, which includes vital signs, cardiopulmonary exam, capillary refill, peripheral pulse evaluation, and skin evaluation, or 2 of central venous pressure, central venous oxygen, bedside ultrasound, or passive leg raise, or fluid challenge. I think in our environment it would probably be easier to do a focused physical exam than the lower criteria, the more objective criteria. So some tips and tricks. Try to use the sepsis order sets. There's a sepsis and a septic shock order set. Those have everything you need in them, and they have a sepsis or shock onset time. The nice thing about that is if you don't state what time you're calling in the onset time, it's going to be when they hit the door, when they register. But you can say an onset time based on when certain things are resulted. For example, you could say it's when I got the lactate back at 4.5. You could say it's when the chest x-ray showed the infiltrate, and therefore I had a source. So you can kind of play the game that way. When you document your tissue perfusion, you should use the sepsis event in the medical decision-making tab, and I'll show you how to do that in a minute. Make sure that one of your diagnoses is sepsis, severe sepsis, or septic shock, so that it gets placed on the problem list. The problem is if you diagnose, fever, pneumonia, hypotension, but not sepsis, it kind of looks like, even if you did everything else right, it kind of looks to the billers and coders and the people looking at the chart later like you missed it. And it's really best practice to order your lactate off of one of the sepsis or septic shock order sets, because MediTech will reflex order if it's greater than 2 for a redraw. Otherwise, you have to remember to reorder the repeat lactate at 3 hours. So I'm going to jump over here to MediTech test and kind of walk you through a couple of these things. So just recognize that in tests, the order sets don't show up like they will in the live version, so you have to search for them, but they should show up under your favorites under sets here in the live version. And so this is the sepsis order set. This is interesting. It's actually a little different than in live, because these things will be pre-checked in live. You may want to order an X-ray. Again, if they're in septic shock, it'll pre-calculate the 30 mil per kilo fluid bolus for you. So again, Plasma-Lyte or LR is preferred. You can choose your empiric antibiotics off of this. It's recommended, if you agree with the choice, to choose the antibiotics off of the order sets. And again, down here, sepsis onset time, and this will flow to the tracker as a sepsis event, but also start the clock for anybody looking at it later. So again, this is the septic shock order set. Again, you've got your septic shock order time, got all your labs, you've got your antibiotics. You can choose different antibiotics. I won't go into, I don't agree with some of these choices. For example, in the pulmonary order set, it does cefepime and vancomycin, which is not what I'm used to giving for septic shock due to a pulmonary source. But again, use the order set for the other things. I'll back out of here and just show you again. So when you're documenting your sepsis, again, a couple important things. Go over to the medical decision-making tab, do a sepsis event. So again, based on the definitions in the PowerPoint there, sepsis, severe sepsis, or septic shock, or you can say ruled out. If you don't think they're septic, you can say why they're in shock. You can say the source, pulse exam, bedside ultrasound. Again, this may need some overhauling to do a skin exam if you want to do a passive leg raise, or if anybody's doing that. And then finally, potentially the most important thing, septic shock as one of your diagnoses. Obviously, you don't want to put that in there if they're going home, but important to get it on the work list. So email me with any questions. Hope that's helpful. And again, just keep this in mind, because all these charts are getting looked at. Thanks.